In this final episode of the Roundtable Season 1, we're going to dig into the controversial topic, shall we say, of evidence care versus complementary versus alternative care versus evidence-informed practice. What does all that mean, and how does it impact who you refer to for your clients and their healing journeys? You're also going to meet Patty. Patty's been someone on this journey who is from Eastern Canada. She's got persistent concussion. She's got some trauma components linked in there, and you're gonna hear me get a little spicy about telling someone there's only one way to heal and how also trauma links in to recovery. Thank you to our sponsor, Neuronic. Again, without you, this wouldn't be here. Thank you for being part of this conversation, and to everyone watching, enjoy. Welcome back to the Roundtable, and if you've been here every week so far, thank you for being here. This is our fourth and final episode for Season 1, and so please join me in welcoming back Dr. Rachel, Dr. Cam, and Dr. Rob. It has been a pleasure having the three of you as part of Season 1 of the Roundtable to share your expertise and your knowledge and your passion. So before we continue, just a huge heartfelt thank you for being part of this project and these conversations. So, as we tend to do, we have these really phenomenal conversations that start as soon as we turn the cameras off. And usually it's Rob asking a question, and then we go down this rabbit hole, and we're like, why didn't we just hit record? I think this has happened every time now. So the beautiful thing is this is actually a topic that Dr. Rachel and I have had before, and that I was talked about bringing to the show today. So we're gonna wrap with our hot topic before our client case on this whole concept of evidence-based care versus alternative, what do you call it, contemporary, and how these play into the decisions you make in supporting your client on this journey, and honestly, what you think about them. I always say, the concussion space, I always say we play in the gray. And I say that because I think that the evidence, we are an evidence-informed clinic, I say, and we practice what the evidence shares, but also I think you need to blend evidence and clinical experience, and sometimes the research isn't fully caught up to everything we're seeing either, or in ways that kind of support what we do. So while we don't make shit up out of the blue, and go here's a thing. There are people that do. There is a time and a place, I think, for what we consider evidence-based and what we consider contemporary care, and we had started to go into this discussion of when it starts to get dangerous, actually, as well, and kind of harmful to the patient. So I am of one mindset that, and I'm going to start, and then you guys can tangent because it's what you do best. As a clinician, recommending care, right? I think all of us that practice in more the Western medicine side of things will lean towards an evidence-based recommendation first. But I'm also of the mindset that there's no one way to heal. And actually, this case that we're going to talk about today kind of highlights that a little bit too. I do believe that there's not one way to heal, and I don't think that I can tell someone exactly what's going to happen to help them better. I can absolutely give recommendations and use my skills. There's certain things that I probably wouldn't recommend, full disclosure, that some of my clients do in terms of the modalities that they choose, but I'm not somebody, unless I feel like it's detrimental and harmful, to tell someone not to do something. If someone's doing something and they feel like it's helping their healing and it's safe, all the power to you. I might not recommend it to someone else, but go for it.
It's what we talked about before, where with the vulnerable population, right? A lot of people can make a lot of claims that what they provide will help this person, and the person wants to feel better, so they go down that path. And I think that I will be the first to admit that medicine there's a lot that modern medicine cannot explain and cannot treat. But I get asked about other providers and other modalities, and right, where does it cross over from, yes, if it's make you feel better, and you want to spend your money on that, then go for that, to being actively harmful. And how much of that is placebo, right? Like, there's evidence that placebo works even when you know it's a placebo. Like, that's how strong placebo is. So, and again, if you're spending a lot of money on a placebo treatment, but it's making you feel better, even if it's because it's a placebo, then who cares, right? You're feeling better. But once it crosses into I'm going to treat your breast cancer with coffee enemas, like, and it's hard for patients who are in that state of vulnerability to know where that line draws. So I generally have a spiel that I tell patients somewhere along those lines, not
Feel free to
not
share.
but that's it. Like,
yeah.
If you find that it's helping you, I say Western or modern medicine, there's a lot that we can't explain, there's a lot that we can't treat. There's not a lot of evidence to support these other practices, but if you are finding that it is helpful and it is not harming you, then go for your life, right? But it's a challenging conversation to have, and even in medicine, there's a lot of dogma that's not evidence-based, and it's important for us as a profession to challenge that dogma as well, and not just like point fingers at other professions. Like, we have to look how we're doing things and the way that we're doing things and how we can make it better. But yeah, that's a bit of a, I get a little bit riled up when it comes to, this topic.
Yeah, no, it's, how many times have you looked at a treatment plan or a case study or something, or I'll do a consult, right? So I consult for people around the world, and part of that is like, what does your care plan look like? And the whole point of a consult is to help just give them the next step, right? And you hear some of the treatment, and I've said this to you before, and I step back and I'm just like, what the fuck is this? Because someone's paying for something, and you hear and again, I'm not an expert on everything, so there's gonna be shit people do that I don't understand, like, absolutely. But some of the stuff, like, I've had clients' treatment plans where I step back and I look at it and I go, like, Rachel's in the clinic, so we're looking at this case, and I'm just like, I do not understand what I'm reading. And I try so hard to keep my professional hat on and be respectful, because I don't know the full story, right? Like, when we're doing a consult with one person, like, we don't know the full story. We don't know how that person showed up in front of a clinic. And so I try really hard to, like, put on my smiling face. But there was one time someone shared a story, and I can't remember the story now, but I just remember, like, I lost all composure. I was like, what the fuck are they doing? And I was just like, sorry, dial that back a little bit. I'm gonna catch myself, because when you see some of the stuff that people are doing, and again, yes, there's shit that I don't know, so I'm like, I always try to have that premise in, but I think it can be scary. And then again, we wonder why these patients get so lost and so confused and spend so much money because of...
I had a patient a very long time ago, and actually haven't thought of this in a long time. It was a lady who came in with a fungating breast mass.
I don't even know what that means.
It means like it was like growing and and like destroying her breast, which was cancer, that she had declined chemotherapy and a mastectomy because her naturopath told her that if she put black salve on it, it would draw the cancer out of the cells. And now this lady was going to die. And was there a window where she could have had successful treatment? And I don't know. I'm not an oncologist. I'm not a surgeon. And like you said, like I don't know this patient's backstory. All I see is what's in front of you. And I'm certainly not saying that, like, it's a spectrum, right? This is the far end of the spectrum. But how do you make sure that you are on, and goes the same for, this is I say you, like including myself and medicine, how do you make sure that you are on the right side of that spectrum, that you are taking the information that is available, and you're right, like evidence often lacks behind, knowledge translation takes a long time. There are certain things that come from case reports and which is the best that we're going to get, or there's valuable information there that you can implement into your practice. But like how do you make sure that you're on the right side of that, doing good for patients and the do no harm?
Mm-hmm. Yeah.
I have a bit of an answer for that. And it's funny, so in optometry, there's a funny thing. Your worst patient is an engineer. Because and maybe that's the same in other places, but it's like also always needs to know exactly why and how something works or doesn't believe in it. So it's like, I'm one of the world's biggest skeptics of anything and everything unless I can actually understand like proven mechanisms of action. And sometimes for me, it's like, I'll actually, and so not only am I a skeptic, but I'm also often sometimes a skeptic of evidence, because it's like, there's times when I'll actually read evidence and I'm like, what you just presented here defies the laws of physics.
Or
optics,
doesn't prove the claim that you're making.
Exactly,
right?
And it's only because you've selectively deleted things from this, but like optics and physics, which is literally just translated math, will tell you that these things will change or not matter. Like a great example of that is there's an eye drop out now for presbyopia. You might have seen it in the news, and it like makes your
presbyopia for listeners?
Presbyopia is like when you pass the age of 40 and you have trouble seeing up close. Okay. And it makes your pupil small. And
the drops do?
Yep, the drop makes your pupil small, so it gives you a greater depth of focus. But with that, what you know from optics, and any kid who did a pinhole camera in school, or anyone who's done any photography or videography, there's definite trade-offs with that. But they will not study some of the trade-offs during that. So then it's presented as though it just does this without actually digging into all of the other places that actually trades off on things. But you don't necessarily need the study to prove it. That's actually just from the optics side. So for me, when it comes down to patient decision-making and stuff like that, there's actually a lot of things that we do that there aren't. Like for some of it, there's great supportive evidence in terms of like the, high-class evidence. For some things, it's like, hey, we know that we can change magnification or minification with a lens, depth perception and other things, because that's just optics. And so it's like you can understand the pathways, but personally how I've gotten around that comes back to that same thing I mentioned a few episodes ago, where it's like, because the most mortifying thing for me ever would be making a suggestion to a patient, having it not work, and if that's been part of my service or my treatment plan or my thing or a product that we have, then that's like mortifying, because you feel awful about it.
You feel horrible.
So ours honestly just comes down to that. It's like, if it doesn't work, we'll take it back. And that's how I get around it. But for me, they're also always, because quite frankly, when I got out of optometry school, I was a total skeptic of what I do now. I thought it was all BS, like complete. Yeah. But that's what I was told by my profs. Yeah. So that's how I get around it. For me, it's got to make sense from a logical, linear fashion of like known and understood mechanisms. I've got to, for myself, generally prove that it's going to be beneficial for the patient, and I feel really lucky because in the optometry world of that means most people can actually see an immediate improvement in that room, but without any coaching that it's going to be better, because you have to be careful of placebo too. So sometimes you put something on somebody and you can make it worse or better, and you never tell the person what you're going to do. But yeah, that's how I get around that, is I'm like, A, I need to understand how it's going to work. B, I need to see it work in action. And there's got to be mechanisms that make sense to me. And then, hopefully, like we're trying to do a bunch of retrospective analysis, hopefully then the data starts to catch up to that too. But yeah, it's hard.
You're in that profession too that is the kind of the opposite too. I would say, like, we do know vision therapy has impact and positive impact after concussion.
When it's done well.
When it's done, yes, as physical therapy, as any profession. But the evidence does not support that yet.
Yeah, no, and quite frankly, and only if the person needs it. But then even when you go into the evidence, like there's a big review that's out right now that basically shows that vision therapy stuff is useless post-concussion. But then it's hilarious, because if you go in and you actually look at the papers that they cited within it, there's a little cherry pick for things that weren't, didn't hold any support for stuff. So it's amazing to be able to go, hey, yes, we actually lack a great, for some vision therapy stuff, one of the only things with like a really good double-blind placebo-controlled study was the thing on convergence. Right. And for a lot of the other stuff, it's actually hard to have that evidence there. So you're running off of this mix of things, but it all comes back to that, hey, how do we do no harm? How do we help people but minimize and mitigate the risk of doing harm to that person in either A, delaying treatment, B, increasing symptoms, or C, negatively impacting somebody financially? Because I think those are the three places that, you know, practitioners can inadvertently cause harm.
Well, and I think in the concussion space, probably for multiple places in evidence too, but like in the concussion space in particular, you can find evidence to support what you want, and you can find evidence to dispute what you want. Like this just, it's present in both right now, and it's that piece of, again, then how does it start to accumulate over the years? At this point, you can no longer argue that early graduated activity for concussion is a bad thing. Like that is good, it is safe, it's been proved over and over again, it is now accepted, even though people still don't do it. But it's that piece of it sometimes, and so this is when I say, and it comes back to, again, the question you guys talked about of the do no harm, and where I say concussion is sometimes I feel like a gray zone, because the double blinds, random RCT studies that so much of multiple of our professions consider the gold standard of evidence, it is not caught up to where we practice, because it's also really, I think, it's hard to create.
So expensive to do.
It's expensive to do. It's usually big funded, I mean, it's usually universities, and you can't have, it's not a homogeneous sample. Like there's just.
Particularly as evidenced by the patients that we've talked about.
Right?
In the
So it's
series,
like, how
right?
do you, how could you.
We're going to wait until we find 100 people with the exact same cases of this, and that. Yeah.
So I think then that throws the other challenge to then is like, well, when we have this like, what do we do? And it's, I think it's that piece of like, we do the best we can, and then we have the flags for the other piece of things.
Yeah, and I think at the end of the day, like having the patient's best interest in mind, but also knowing what your objective and subjective outcome markers are, so that continuously, even within one single treatment session, you're continuously testing and retesting, right? And it's like sometimes there might be something that I do where I'm like, hey, I can't fully explain this, but I have a gut feeling that like this might help reach this end goal, and are you open to me trying it?
And that's experience,
yeah,
right?
Yeah, exactly. And then that's where it's like, okay, well, I know what, if this does work in the way that I want it to, this is what I should see as my end result. And sometimes that's testing it out and playing around with things in the office, but if something's not working, I'm not going to continuously do it. And at the very least, I should have a reasoning of why I'm doing it.
And I think that's that's kind of one of the flags that I say to patients, right? So when patients come out and they're like, I don't know if I should keep doing this therapy, I don't know if it's good therapy, and I'm like, well, have you had a conversation with the therapist, and can they explain what they're working on and why? If you as a therapist can't explain what you're working on and why, you are fucking throwing shit at the wall and hoping it sticks, and you're lost.
And then if you don't have metrics as to whether it's improving or not, like the case we discussed the other episode where she's in vision therapy and it's getting worse and it's doing whatever, I'm like, what the heck is going on here? Like there's a missing piece of that puzzle, because, you know, if it's not making, I'd say, objective and subjective improvements, you know, then what are you doing? Yeah,
and I think I hear so often of the case of like, ugh, you know, sometimes you just want to beat your head against a wall.
Speaking of concussions.
Of the, like, you just hear these poor patients going to therapy, and maybe it's because like this is all I see every day, right? So like when it's all you see, you hear the nuances in the histories that you're like, fuck, why has no one looked at this? And they're going back over and over and over again, and you can tell the therapist has no fucking clue what they're doing, because they are literally, they can't explain it to the patient. They're throwing stuff at them. There's no change happening. The patient is terrified to ask a question because they get their head bit off when they ask a question. And it's like, those are all, like, none of that shit's okay. And so I always say too, like, that is one of my, like, when people are like, should I stay with this therapist? Should I stay with this therapy? That's one of my flag questions is, you should feel comfortable asking your therapist, what are we working on? Like, what is the treatment, like, what's our treatment plan here? Like, you know your functional goals, but like, what are we working on? Can they relate how that is going to be a part of what functionally you're trying to achieve? And what is the treatment plan? And if they can't do that, or can't give a working theory as to what they're trying because X, Y, and Z, then that should be a flag that you either that therapist does not know, or they need to like start digging deeper or ask more questions, because I think that's just trouble.
I also think if they're telling you that you need to buy something that they only provide, right? Like, you have this deficiency that conveniently I sell samples of, Or they're telling you not to see other practitioners. Like, don't go see your family doctor about this. They can't help you.
Yeah.
Those are pretty big.
Those are, yeah, that's the other big one. You can't see anyone else. Stop seeing
I mean, the hard part
everybody else.
is sometimes, though, to be fair, there will be a service or a thing that only
But they
that
can
person can provide.
And there
because
will be
that's
times where you
there.
do want to halt other services, but you can explain
Oh
why.
no, I mean in terms of recommending something you provide.
Oh,
So
yeah.
it's like, you know, it's even if you're like a general contractor, you're like, well, here's a recommendation, we got to build this, and you're the one who provides it. But I think you're right, especially you almost talk about it like if you're like a significant other who's isolating somebody. It's like, you know, don't see your other practitioners about this, don't involve this, don't, you know, whatever. But it is that balance of using the evidence that's there, the understood systems, and again, I like that term, it's like evidence-informed care. But I think part of the informed is also the informed consent to the patient in terms of, you know, what supports what approach.
Yeah.
You know, we have to do that sometimes too, where it's like, hey, you know, this drop or this thing is proven to do this. It can be used off-label for this sometimes too. The evidence isn't necessarily there for it, but clinically we see a lot of improvement when we do this. So, you know, are you good with that? And, you know, it's, yeah, patient-informed care.
And I think it comes back to like how you present it, and without like, you're very neutral. Here's this, X, Y, Z. Whereas I think sometimes people feel pressured into doing.
That's also a bad
the
sign too.
pressure
If
is a
there's
bad
like,
sign,
yeah.
right? Like if you're like, here's this, blah blah blah. We sell it, cool. We sell vagal nerve stimulators.
And if you sign
like,
up today, it's less.
good old marketing. But if you're feeling pressured, like that pressure from like a specific thing, I think that's also like for sure that flag. I'm going to dive into our final case. We can chat about this how we want. This is Patty. And I'm not going to lie, Patty was one of those people that I was like, when she was sharing this, I was like, I'm going to lose my shit. But I'll share why in a moment. So Patty is 61. She is a fellow Canadian, lives in Prince Edward Island. Have you ever been to Prince Edward Island? I haven't.
Yes, I have. But I was very young, so don't ask me anything about it.
It's on my bucket list for one day. So she was an LPN in a family private practice, worked with 2 nurse practitioners. This was her second career for her. She loved her job. She absolutely loved it. Her favorite part, she did emergency medicine as well. But her favorite part was being what she could do to help people. And so in the family practice, what she loved is she actually got to support people through all aspects of life, babies to old people. Her hobbies are gardening, painting, was really big into hiking and challenging hikes prior to this concussion, and wants to be able to build back up in hikes again. Past medical history, PTSD, agoraphobia, menopause, and then a torn rotator cuff, had surgery, and it was, by her words, a horrifying experience. I did not ask her to dig into that. Medication, she's on estrogel at the lowest dose, prometrium, venlafaxine, which is an antidepressant. Okay. She's taking this 4 days 1 week and 3 days the next. Is this like, I always find like with medications or anything, like dosage is.
Yeah, it's a little bit of trial and error, right? Like that's not normal, but maybe that's the way that it works for her.
And then she's taking some other meds that I don't know what they do. She gets a lidocaine infusion every 4 weeks that spans over 2 hours for headaches. She's had 6 treatments so far that she says seem to have reduced the severity of her headaches that have helped. So this current concussion was on December 29th, 2020. She was at work when a mother came in with a set of newborn preemie twins. And mom was like carrying both babies in, so not in car seats. So like trying to carry these 2 preemies in. And Patty's job was to weigh and measure them, was ultimately what she was doing. She was holding one of the infants, and she had just finished measuring and turned to walk to the counter, and she caught her foot. And she says she describes it as falling like a timber tree. And she fell holding the baby. And so Patty struck her head on the corner, like on the counter going down, and then landed flat on her back with the infant in her arms still. She describes the incident as terrifying. All she could obviously think about was the baby, and was the baby okay? Baby was okay. Everyone watching, baby was fine. Immediately, sounds were muffled. The room started to go black. She couldn't see, so she lost vision. She crawled out. She actually was not bleeding, so she like hit her head, had a little scratch, but like no blood. Crawled out of the room on her hands and knees, and sat on a stool there. And then the nurse practitioner went and finished everything. She had an ice pack on her head for probably about an hour, stayed at the nurse's station, complained of blurred vision, headache, confusion, and then she bumps into walls and door frames as well. She did not go to the hospital, did not have any imaging done. She drove herself home even though she felt woozy, and went and laid on the couch for the next night. She went back to work the next day and did the basics of checking people in. But then the next day, so she had a big hematoma on her head, she said. And so then the next day, the bruising and swelling had like come down. It was all around her eye socket, and she had a horrible black eye that lasted for about 3 months. She did go see her GP that day. Physician told her if she had any symptoms to not go back to work. And she's basically been off work since, minus a attempted and failed return to work. When she did try to go back, she tried to hide the challenges she was having. She wouldn't hold an infant. She would get confused taking histories and have to redo them. She'd bump into things, the headaches, the fatigue, and about, I think she said there was a typo here, about 10 months in, work called her and said, we need you to take more time off. So this was a huge hit to her. The way she described it, her basically felt like she was in the way, and there was kind of that piece of things. I also asked her, I've never met her in person, but we did a Zoom call with this one, and when she was sharing the incident, I said to her, I had to stop and make sure she was okay, because you could just see the heightened emotional effect of when she was recurring the history of what had happened. So my brain automatically is flagged to I need to make sure, I'm hoping she's with that PTSD component, that is being looked at. I'll talk about that in a second. She saw physio in the beginning, worked with him pretty basically, I'm not gonna lie. It was more neck, back, upper shoulders, acupuncture, aerobic conditioning, and that was it. Then she got put into a WorkSafe program. I'm just gonna sum it up to say it was hell. They pulled her out of it. Her case adjuster pulled her out of it. She went back to physio. Anyway, she's seeing physio now, I feel like. I think. Skipping ahead.
Yeah, that's where you were.
Okay,
Yeah.
Awesome. So she feels like she's improved from the beginning days. She's not back to work because of dizziness and those pieces. In the beginning, though, she said she couldn't even unload a dishwasher because of how dizzy she got, and so she can do these things. Today, she still says dizziness is a big problem. If she rolls over in bed, she gets so nauseous she wants to vomit. It's like she's living on a boat. She also feels like she's on a merry-go-round. She said she recently went to test a recliner and it was awful and got super dizzy and had to stop. Spatial awareness is an issue with bumping into corners and tables. Balance, going up and down stairs is super scary. Visual motion is really hard, crowds, all those sorts of things. Unstable surfaces, incredibly challenging. And then she almost feels like her body overreacts to the stimulus. Anxiety is a big one, crowds, panic attack. She had, a couple months ago, she had 3 panic attacks in 3 days. They tend to be very visually overstimulating environments that trigger them. And then her legs don't want to work and she freezes and then everything just shuts down. One was in Costco. She got one from a doctor's office when she came from lying to sitting as well and started hyperventilating, and that piece of things. So her job was given away to someone else 2 years ago, and this was a very devastating kind of component for her. So there's a few things. She sees a neurologist. She's the only person we talked to that has a neurologist on their care team. This is no bash to any neurologist that watches this video, but I don't find them very helpful.
Most of them don't do concussion. Our concussion clinic is and TBIs is physiatrists. Yeah. So I think this is not a common thing for neurologists.
But you know what's interesting is because it's the brain, every general practitioner will refer to neurology, not physiatry. And so again, I think that's a piece of that education component. And so I always say to people, because they wait 18 months in our healthcare system to see a neurologist. And
That would stink for the neurologist, because the person's in there wanting them to solve the concussion. There's
this
nothing
is
worse
what
than
I
having
do.
somebody who wants you to do something different than what you like to do and what you do. And,
And so most experiences are, full disclosure, negative, because it's the wrong referral, and most neurologists' toolbox is medication. And sometimes they do other things, or it's but this is not their area.
When I was an intern, so my first year out of med school, I went to, I was on a medical ward, and I went and I asked the social worker to do something, and she looked at me and she goes, "You have no idea what a social worker does, do you?" Like, clearly not. And I think this is the same thing, right?
Yeah.
Like, people who are referring to a neurologist clearly don't know what neurologists do.
Yeah.
Yeah. And it's just a lose-lose for both of them, right? She's seeing a neurooptometrist in Halifax, just started, was given some prism lenses and such. And then I'm gonna go on a tangent in a second here. And so she is seeing a psychologist. And she's seeing a psychologist once a month. And she said they really clicked in the beginning, but her PTSD, so she's seeing the psychologist for her PTSD. And I'm gonna put money on the fact that, and not everyone likes to hear this for sure, especially like if they are the client. If someone has persistent symptoms, there is almost always a trauma component to the picture. This is why we have a clinical counselor on my team. There is almost always a trauma component, whether the incident itself was traumatic, whether the process following was traumatic, whether you're dealing with grief because you've lost your life was traumatic, whether there's pre-existing trauma that has nothing to do with how you got your concussion. And when we look at, I mean, when you start to pull the studies around trauma, like chronic trauma is not an actual term, but like the long-term effects of trauma on the body, some of them are the same as the symptoms of persistent concussion. And I always say that it's the system you bring into it. And so pre-existing trauma, although it might not be directly related to concussion, just elevates or decreases the capacity your nervous system has to handle increasing stressors or those pieces of things as well. This individual, the psychologist that she's seeing for the PTSD component, because I do think there is still a big piece of that for her that is part of her issue, especially when we're talking about the panic attacks, the fact that she got, and she knows I'm going to say all this, but how like you could see the emotion when she talked about the incident, like it's still it brings up a lot in her still, right? And so I do think this is a piece for her, not even related to anything that any of us do, needs to be addressed. But her psychologist was saying, well, the only way to address it is exposure therapy, which to me is absolute complete bullshit.
I guess again, like the logical part of my brain kind of goes, okay, what environments, what situations brings up your PTSD the most? So, you know, again, my clinic is biased towards, visual stuff. I'm not biased in the sense of, but that's the patients who self-select or who are referred.
And I'm not going to disagree with you on this either.
So we'll see people where it's like, busy visual places will kick up their PTSD type symptoms in other environments. And vision's just one of the other ways it can cause that fight or flight system to go up. And then I think I agree with you. If there's traumatic stuff, the amount of my post-concussion patients who've actually said that in the process of having to deal with all their concussion stuff and other things they've had to do, they've had to deal with some things that they were refusing to deal with in their past beforehand or didn't even know were there as issues. But I think you're right, it's just one of those other things that keeps their system in that fight or flight response because, I mean, it's fear. Yeah, and if you're in fear, you're in fight or flight or shutdown. Like it's, fight, flight, shutdown.
And I think this also goes back to there's not just one way to heal too, right? And so for this client, I said to her, this is one of those scenarios where I'm like, I should probably bite my tongue. But if you're looking for permission to find a different therapist, this is your permission slip. Because exposure therapy is not the only way to heal and work with PTSD at all. And for this individual, especially given they're already living in fear, right? They're already elevated. They already get emotional when they share it. And then there's the other stimuli that then bring it even more and kind of push it over the edge. But to then be told, and then this was just me being a smart ass when I was talking to her, but to be told that you need to go into the environment and you can't leave. If it's gonna trigger an attack, you have to stay. This is how she took the information from her psychologist. You can't leave, you have to stay there. And I was like, well, A, that's not how you do exposure therapy anyways. Like that is not proper exposure therapy. I said, B, what are you gonna fucking do? Hold a doll and practice falling with an infant over again? Like this is what she's telling you to expose yourself to the traumatic situation over and over again, to expose yourself to it, so you habituate to it. And like I have so many issues with that. It's not even funny. And so I think from a trauma piece of things, it's recognizing like there are other tools, EMDR therapy, somatic therapy. There's things called like, I don't know much about brain spotting, but I know some therapists who swear by like brain spotting now. EMDR was a friggin' godsend for me and like my PTSD. Like it is the thing, and it's not everyone's the same, but EMDR was 100% the tool for me that helped me start to move through my traumatic pieces and integrate that so I can talk about things now. And that, like, you don't forget the memory, but that emotional trigger is no longer there when I talk about it. And so for her, one of the big things for me that stood out in it was, again, yes, she gets triggered by the visual piece and that element of things. And like, yes, the postural changes and there's all these pieces. But one of the big things for me that was like, if this isn't being, luckily she's now switched to a new clinical counselor, by the way. But one of the big pieces for me that popped out was that even just sharing this scenario. So we're not in a visual stimulating apartment, like we're in her home where she feels safe, like all things should be contained. And even just sharing that story of how her concussion happened brought up so much in terms of the symptoms she was feeling, the emotional response. And so for me, when we're looking at how do we prioritize care now and work with the care team and who do we refer to, like massive flags to be like, that is somebody that needs to have either a psychologist or a clinical counselor or something on their team, because there's layers that need to be worked on that if you can work on that piece, like you said, sometimes it's an invitation to work on something you didn't know you needed to work on. It's going to positively domino into everything else that you're doing from a rehab perspective and kind of going from there. That's for her, honestly, I'm not going to lie, like that was one of the biggest, there's obviously other pieces and please feel free to share, jump out, but that was one of the biggest things for me, and then I just got really angry when she shared.
Well, because the exposure therapy, it's kind of like telling somebody to go do more running.
Yes.
Okay, well, great. That works if you've made sure the knees are fine, the ankles are fine, the gait's fine, they're not iron deficient, like whatever all those other things are. Is there a time and a place for more running? Like, totally. For sure. But again, that very logical part in me is make sure that all of the things they require to do that are actually working properly. Yes. And some of that may be the emotional processing of the whole event. Yeah. And the fear of loss of future stuff too. Like that's a big thing.
Yeah, no, absolutely. It's just, I think over our 4 cases too of what we've seen is every single one of these individuals is unique. And while there are obviously commonalities, which ideally there should be, but while there are commonalities, that piece of the order we address things, how we address them, how we work with them can shift person to person, which is where sometimes I think this space gets so complicated because we don't have a checklist, right? Like you don't have a black and white tick, 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 tick with each person because unfortunately, it's not.
I feel lucky in the visual world. It's like, it's actually not that bad.
It's
Like with the way that we've developed our systems for things, it's very much like measure these things, do this stuff. And for every single person, you make sure they're supported in all the same ways. And quite frankly, whether they're post-concussion or not, you still do that because then, you know, the amount of people who deal with some computer fatigue by the end of the day, whatever, it's the same mechanisms people are suffering from post-concussion stuff. It's just the post-concussion is way more sensitive. So I actually feel lucky in that sense because in my world, it is very much like, checklist, if this, do that, if this, do that. And then there's the nuance around when it comes to actual therapy and co-managing, then yes, that part's different, but.
I mean, we have a standardized assessment for everybody. Yeah. You come into the clinic, whether you come in with FND, concussion, I don't know why these symptoms showed up, but these are my symptoms. We have a standardized assessment that everybody goes through because that's how we start to make our treatment plans.
Because then you understand what's going on and what areas you want to deal with and when.
The nuance comes to, I think, like you said, it's the co-management, it's the treatment, it's the factoring in the sensitivities, that piece becomes the nuanced element of things.
I think like with the 4 cases, all those patients have been going through this for years, right?
Yeah.
The question that I have, and I think that it's important to address, is obviously these are the cases that stood out for a particular reason because they're especially complex. But do people going through this get better?
Yes.
I'd say the majority of people that we've seen through our office and that we've shared and that we've whatever. I'd say the vast majority do. And I'm often convinced in the times that they don't, there's like a single aspect that's missing. Like I remember there was one case where it was like the eustachian tube thing. Once the lady had that addressed, that seemed to be like the part of the math equation that wasn't adding up. Or there's almost always like a piece.
I agree.
Yeah.
When we get the people that have been, and it's something was missed along the process, and just the whole picture, like something was missed.
Yeah, that again, my brain works at it like a math question. That's just yeah.
But 100%, it's like, I think that's why we kind of tout it. Like I always say, I sound like a broken record because you can get better. But the care you receive very much can play a role in that too. And I think an important thing, like the cases we talked about were very much persistent, right? They're 2+, I think some of these are 2+6 years, maybe a little bit longer.
But they're usually persistent because people have missed some critical factor.
Exactly.
It's
or
like,
they've done way too much and just like shot the patient's capacity.
yeah, which is also again like a critical factor.
Yeah, exactly.
Like
So it comes back to that piece of if, from like an education, awareness, training standpoint, if we can do a better job at identifying, referring, and then treating the acute and not missing shit, then we're gonna see less of this, which is what we all want.
My profession's probably the one that may be the most guilty for missing stuff sometimes because we're not really taught about it properly. So the amount of patients I've had come where they've done all this vision therapy, they've done all of this physio, they've done all of the functional, like all of these things, and nobody addressed the fact that the person's progressive lenses were distorting their depth and spatial perception, or they had them working at their computer in glasses that are not really designed to be doing that properly, or the woman's set up with one eye close and one eye far after her laser or cataract surgery, and then you address that, and then all of the other modalities start working properly. But it was like this fundamental underpinning, and so yeah, I'm a firm believer that usually in most of the people where it's persistent, it's just like there's something that's been missed in that overall equation, and then it's like the big math problem. You keep coming to the wrong answer because one thing is wrong.
Yeah, I would agree. Any other thoughts, comments as we wrap season 1?
On this one?
Yeah, go for it.
I think one thing massively that I'd just say from the visual area of stuff and what I've grown to know over the last like 12 to 14 years of that is when it comes to glasses, prism, whatever, this, that, or the next thing, for the people out there, they should be able to see generally a pretty immediate improvement in function or symptoms, either in the room with the optometrist when they're prescribing it, there should be noticeable difference. Right. I get concerned with a patient sometimes when I'm testing things out and I actually can't get a change to their balance or their dizziness or their reading or their screen sensitivity or whatever it is. Then I'm concerned because I don't want to prescribe something unless it's actually going to give them measurable benefit. But when it comes to a case like this, the question I'd have immediately is, are your glasses helping you in those environments? Are you seeing improvements to those things? Because that often helps guide whether it's on the right track or not. Because if it's not helping, then they really need to have a discussion with their provider.
Yeah. Before we turn off the cameras, because we always turn off the cameras, and then one of you has a kick-ass question, and then we tangent for 5 minutes.
It's usually Rob. Rob's got good questions.
Rob, is there anything else that's just like, watch, we're going to turn off the camera and you're going to do it?
No, I don't think so this time. I think we've addressed them. Yeah.
We've got them all?
Yeah.
All right. Well, friends, thank you for tuning in to season 1 of the Roundtable. I hope that you've taken some gems, whether you're on a healing journey, whether you are a clinician listening to this. All the contact information is obviously below. Reach out. We will be back in the spring for season 2. Take care.